All right. Welcome, everyone. We are so happy you're here today. This is our very first of our Rare Disease Parent Bootcamp series. Our hope is the information you hear today and future series will facilitate the journey for those of you who have a child that is facing a serious health crisis, or if you are an advocate helping these families. When you have a child, you want the best for that child in every way. And for parents of children born with a genetic disorder, correct diagnosis is the first step to receiving proper care. Unfortunately, there are many logistical and financial complications that make the Diagnostic Odyssey challenging for rare disease parents. We're very lucky to have these three panelists with incredible backgrounds and experiences that we can learn from, so that if you are a parent, their experiences can speed up your journey. And if you are an advocate, you can learn the latest resources and advancements. Amber Freed and Brittany Stineman are parents who have walked the difficult journey of not only facing the difficulty of having a very, very sick children, but also the barriers to finding care for them because of the rarity of the disease and the rarity of the availability of treatments. And Holly Snyder is a board certified genetic counselor who looks at it from a genetic testing angle that can carve a path forward thanks to the clarity that comes from a diagnosis. I'm going to take a moment to give you more background about each of our panelists. Amber Freed is the mother of Maxwell, who has SLC6A1, which is a rare neurological condition in small children that causes seizures, severe movement and speech disorders, and intellectual disability. She's the founder of SLC6A1 Connect and is raising $4 million to advance a clinical trial that will cure every child with this disorder, including Maxwell. SLC6A1 is the 10th cause of autism, the 6th cause of epilepsy, and plays a major role in psychiatric conditions. We also have Brittanys Story. She is the mother of Nash, who had multiple hospitalizations until he had a genetic test at 11 months old that revealed he had spinal muscular atrophy and respiratory distress, SMARD. Not to be confused with the more common and well-known SMA that has 3 treatment options. After being told Nash did not qualify for a clinical trial that could save his life, she and her husband Bobby founded Smash SMARD and has raised over $2 million to fund the development of a gene therapy intended to save the lives of SMARD patients. The organization has funded preclinical research and the human-grade clinical product that will ultimately be used in a clinical trial. And Holly Snyder is a genetic counselor at Illumina, a global leader in genomics, having innovative technologies for the analysis of genetic variation and function. Not only is Holly extremely knowledgeable in her field, she is passionate about helping rare disease families. She decided to pursue a career in genetic counseling because she loved the idea of combining patient care and advocacy with genomics, especially given how rapidly the field of genomics continues to evolve. Although she has worked in several different roles throughout her 17-year career, the role she has now is the one that most excites her because of the amazing potential she has to help families impacted by rare diseases through genome sequencing. And I, Sasha Whitaker, am your moderator today, and I am Director of Technology for American Gene Technologies. AGT sponsored this event in support of families affected by rare diseases. AGT is a biotech company in Maryland developing genetic medicines for rare diseases with a lead program in phenylketonuria, a rare disease that affects 1 in every 13,000 births in the United States every year. AGT is deeply committed to supporting each of these moms and the rare disease community, including Illumina, and we are delighted to be hosting today. I was hoping that we could start with Amber. Amber, could you start from the beginning and tell us what happened and what it took to get the diagnosis for your son, Maxwell?
Well, thank you so much for the opportunity to be here and speak. I can give you a little bit of background about my patient journey. I had beautiful twins in March of 2017 named Maxwell and Miss Riley James. They were beautiful and perfect, and I like to say, if we had the opportunity to be on the cover of People magazine, they would have sold more copies than the Brangelina twins. We brought them home and life was perfect. Soon after we brought them home, I noticed that Maxwell wasn't advancing like his benchmark, his sister Riley. He wasn't meeting developmental milestones. He didn't sleep. He screamed all of the time. And so I'd go to the doctor and I'd say, look, my baby feels floppy. He's not meeting milestones like Riley. And everybody told me, boys are slower than girls. Don't compare twins. You're a nervous new mother. And all of those things are true. I'm the most nervous mother. But as time marched on, mother's intuition became stronger that something was really, really wrong. I took him to the eye doctor because he had this strange stereotypy where he'd stare at his finger 12 hours a day, and I'm going to do it. And he would cross his eyes and look at his finger, and I thought, well, maybe he can't see. The ophthalmologist said, I can tell you he can see, but I can't tell you if he's going to live. I was so shocked. When do you hear that from an ophthalmologist? I would expect that news from a neurologist, a surgeon, anybody else. And I looked and said, I don't understand. And he said, I see so many of you. Parents come to the eye doctor thinking their babies can't see, but it's their brain. And it's nearly always a rare disease. There are 7,000 rare diseases. Don't bother Googling. Just prepare yourself for the worst. And I said, what do I do next? And he said, get genetic testing. I'm so glad I was able to. After a very long fight with insurance, I received a panel test, and our worst fears were actually confirmed. Children's Hospital called and said, Amber, come in, we'll clear our schedules for you. We drove to the hospital shaking. We were led to a sterile, cold room with a lot of doctors with sad faces. And the doctors said, your child has SLC 6A1. And I was so confused. That's the name of a flight number, not the name of a disease. And I was frustrated. The doctors were speaking slowly. So I took out my phone and I Googled it. No search results found. They said Maxwell is one of 34 in the world. Nothing can or will ever be done. Give him the best life you can. We found out that this finger motion was a stereotypy really particular to this disease. And it wasn't until my big 6-foot college football loving husband started to shake from crying and just sobbing that I realized if anything was going to cure this disease, it was going to be us, and I was going to fight like a mother to help Maxwell. Left my career, and that brings me here now.
Thank you so much, Amber, for sharing. Brittany, did you have a similar experience? What happened with NASH?
So interestingly enough, I had a similar yet different experience. Prior to getting pregnant with my oldest son, who was 2.5 years older than Nash is, I had expanded genetic screening. I am of Jewish descent, and so I had a panel to rule out all of the most common diseases that they find in Jewish ancestry, and everything was perfect. So we had our first son. Well, in between our first son and Nash, we had 2 miscarriages. And I was convinced that there was something genetically wrong. And everybody told me again, just like Amber, you're being crazy, you're fine, this happens all the time. So we went on, I was pregnant with Nash. And during my pregnancy with him, I started to realize that he was not moving very much. And then towards the end of my pregnancy, he stopped growing in utero. And they told me that it was because I had high blood pressure and that I had placental insufficiency. Well, then he was born, and just like Amber, everything seemed, he was very small, but he was small and mighty, like rolling over at 2 weeks, which was sort of a clue that something was wrong, actually. I was like, this isn't normal. You're not even supposed to be born yet. But so he seemed to be really progressing normally. By the end of his first month, he was 8 pounds, like he gained, but then fast forward a couple months, we started noticing a drop in his weight gain to a point where it just completely halted. And then also some respiratory symptoms, something called laryngomalacia. Well, I started bringing him to specialist after specialist, and he had a surgery for his floppy airway. And, fast forward, we just like Amber, we kept taking him places, and everybody, what they were telling me was that there's nothing wrong with your kid. Nash had two key characteristic symptoms of his disease, which was that he had a diaphragm eventration, which is very uncommon in a normal population, let alone a pediatric population. I think there's only one other disease that it's been truly described as a characteristic. That was at around 5 months. And then he also had a foot drop. And my husband and I took him to a lead pediatric orthopedic doctor. And the doctor looked at me and he said, he has something called metatarsus adductus. He will grow out of this. Well, then, so the natural instinct is to believe that doctors walk on water. And they do, don't get me wrong. They have been monumental. The right ones have been the best things that have ever happened to us, but the wrong ones can really lead you down a bad path. And so, fast forward, we just kept trying to figure out what was wrong with him. And finally we were like, all right, after his diaphragm hospitalization, we had to bring him in for the long haul hospitalization to figure out, he can't live at 12 pounds for the rest of his life. So at around 5.5 months, we hospitalized him, and they were telling me that there was nothing wrong. And so I was begging for genetic testing, my husband and I said, we will pay for it out of pocket. They were like, we don't do whole exome sequencing inpatient. I'm like, okay, I don't believe that to be true, but whatever. And actually last night I pulled this from our hospitalization, and I think it's very relevant to this conversation, because the symptoms have to match what the physician is reporting to somebody like Holly. And what they found in Nash was so much different than what I was seeing. It was genetics consulted for evaluation of genetic cause of lower tone extremity, undescended testicles, and failure to gain weight. Nothing to suggest a genetic syndrome, no further workup necessary. They didn't mention his diaphragm eventration. They didn't mention his respiratory distress. They didn't mention how severely he was failing to thrive. He was like 500% lower than where he should be. And they said that GI was consulted for diet. Dietitian was, for diet. Dietitian consulted for diet, speech, but they didn't want to face the challenge. So finally, in that hospitalization, I'm like, all right, now I'm starting to feel crazy, but I have to figure out the answer. Fast forward, we demanded a transfer. We wound up at a different hospital, and they rushed genetic testing in 5 days and had results in 5 days. And we had gotten the diagnosis that I dreaded but prior, I said I could never imagine having a kid with SMA. Granted, Nash doesn't have SMA, but it's a similar presentation of the disease. So when they came in the room and they told us that Nash had SMARD and that there were only 50 other kids living with this disease, it was really devastating. And where I can, with same thing as Amber, they said, you're never going to have an option. Nobody's researching this. You're never going to be able to do anything. So backtracking in our first hospitalization, I go from there's nothing wrong with your kid, and the only research that's out there now is that your kid is going to die. He had the diagnosis at 11 months finally, and every single piece of literature said 13 months was the life expectancy of a patient with SMARD. So in my brain, I went from there's nothing wrong with my kid to your kid's dying in 2 months. And I didn't believe it. I'm like, nobody is going to put an expiration date on my kid. So to Amber's point, like no option's not an option. I don't know who's going to do it, but I'm going to have to figure out how, because nobody else is doing it for me. And so that's exactly what I did. I called researcher after researcher, and and there's a lot more that I could talk about, but I think we'll kind of move on to the next thing.
And that's what I wanted to actually ask, because both of you had a similar experience where they said, there's no treatment, there's no cure, make them comfortable, the end is coming.
Mm-hmm.
What on earth did you do in that situation?
So at the time, I didn't understand that SMARD and SMA were not the same, thankfully, because at the time of Nash's diagnosis, they were coming out with a phase 2 trial for what is now Zolgensma for SMA. And so I wanted to find the researcher I wanted to understand why Nash wasn't going to qualify for that treatment. I didn't understand it. I didn't understand genetics. I didn't, I was just being thrown into this world. And so I called Brian Kaspar, who I consider to be the godfather of gene therapy, and who was the person that developed. And he really sat down and explained to me, after some pounding on his door, he sat down and explained to me that that he wasn't a candidate because it affected a different gene, but he also instilled the faith in me to know that I was going to be able to do something about it. And, he's been a guiding light for me throughout this whole process. And I interviewed 50 researchers and wound up, we wound up working with the woman who took over his lab, and her name's Dr. Catherine Meyer, who's absolutely amazing. So that is real in a very, very small nutshell how we move research forward, but that's how we got to where we are.
That's amazing, Brittany. Thank you for sharing that. Amber, did you have a similar, what did you do in this situation?
It was a little less direct than that. I went home and had to read a lot of textbooks to understand what this meant, and microbiology and the neurological system. And luckily for us, SLC6A1 encodes for the body's most important inhibitory neurotransmitter. So I started calling people who understood GABA. I called close to 300 scientists in a month. I would stay up all night using a voice recorder because I was so tired I couldn't remember the conversations. And if I needed to go back, I had to listen. And I kept hearing kind of a similar message that, and this is going to go above everybody's head, but SLC6A1 is a heterozygous missense mutation that it's a loss of function, fits easily into AAV9. So what that means is we're a candidate for gene replacement therapy. So that led me to the next step. There's only a handful of people in the world that can do this. And it was very hard to get their attention because there are a lot of Brittany and Ambers out there. And they get these phone calls every single day. So I really had to differentiate myself. What did differentiation look like? Creativity. I would send them snacks via Uber Eats every single day at 2 or 3 because nobody can turn down a cookie during an afternoon lull. I would show up to conferences where they were speaking and just corner them. But I would also show them that I'm a good partner. I'm going to raise the $4 to $7 million. I can handle a patient organization. I can find patients. I can find all of the doctors that can help you advance a genetic treatment as quickly as possible. The hardest part has been balancing all of that because, of course, I'm doing a lot of amazing things, but there's a large opportunity cost. This is taking time away that I could be with Maxwell, and it's all encompassing.
I couldn't agree more with that. And I made mine in a nutshell, and I probably made it sound more straightforward than it was. A lot of the same things Amber did, I did to differentiate myself. And also I was constantly sending pictures and videos of Nash so that people could really empathize and see the human side of why their careers and their jobs and why they chose to be scientists. Why is this so important? And the bottom line is, especially for researchers, it's always about the patient. So if they see that there's something that they can do and you can differentiate yourself, and then you sort of get your foot in the door and you just keep things moving in that way. But there's, to Amber's point, there are so many different facets of trying to keep every ball in the air between the nonprofit and caring. Like Nash's care is so intense. I won't even go into it. It's more intense than I ever imagined. And then also making sure that you're fundraising. And I have a 7-year-old and I now have a newborn, and trying to make sure that you're keeping their lives as normal as possible. And you have a husband who you have to keep happy. And it's just this cyclical thing, all while you have to keep this kid as safe as possible so that you can even get him to treatment, So it's not as easy as I made it sound, but it is, and it's a ton of work. But in the end, I wasn't willing to accept the fate for my child. And so and to Amber's point, there are a ton of us out there. It's just channeling your inner like mama bear and getting out, or daddy bear, and getting out there and figuring out how to make things happen.
Well, I think it is an incredibly tough journey. And I think anyone going to either one of your LinkedIn pages would agree. Brittany, I saw a post from you recently of what a day in the life of taking care of Nash is like, and I was shocked. I had no idea how incredibly difficult it was. I encourage everyone on this call to check both of their LinkedIns to just see what life has been like, to understand. And I'm sure there are a bunch of people on this call that can relate to what both Amber and Brittany are experiencing. And that's why we're doing this call. We want to help and share the experiences that they have, so that, if you're in that position, you know the journey that they went through and have the tools and resources to be able to act. And we're incredibly lucky to have Holly on this call, Holly Snyder from Illumina. And, Holly, just people are overwhelmed at this point of this diagnosis. There's a lot of information to absorb, and not great news, not good news at all. And a lot of people are coming to the terms of the potential consequences for them. Knowing that, what advice would you have for families in regards to educating themselves when they do have a diagnosis like the ones Amber and Brittany received?
Let me just start by saying, wow, Brittany and Amber, I've heard your story sort of secondhand, but just hearing you both speak, and I've heard these stories from parents so many times now in my job, and I still just get chills and almost onto the verge of tears, because as a parent, I can only imagine what it's like to fight every single minute of your day for your child. So I just want to thank you for sharing your stories, and thank you also, Sasha, for having me. So it's an interesting question, and I think to put it into perspective, it's important to think about where a family is in their diagnostic journey. So we've actually gotten to a place in pediatric genetic testing and pediatric rare disease where parents are getting an answer in the NICU before they're even discharged from the hospital. And so you have a newborn baby hooked up to machines, you're overwhelmed with decisions. Every minute of the day is critical for some of these babies. And now we're at a place where rapid whole genome sequencing can be done. And in some cases, these babies can be diagnosed very, very quickly. Whereas the other end of the spectrum are the families where they've been on this diagnostic odyssey. And we know that the average diagnostic odyssey is 5 to 7 years. And these families go through 2, 3, 4 misdiagnoses and see countless numbers of specialists and physicians throughout that process. And so depending on where you are in that diagnostic journey, you may be ready for this information. You may be ready to embrace it and just desperate to get an answer. Whereas for others, it could be very overwhelming. So I think it's important for the family to first ask themselves, how important is this diagnosis for us? What will this mean for us? Will it change anything for us? What is the utility of the diagnosis? Meaning, will it change management? In many cases, like what we're hearing here, having a molecular diagnosis, so a genetic cause, opens up opportunities for research, gene therapy, just even simple medications that wouldn't have been used in a patient with seizures that might be used with a specific gene disorder can change the impact. There's also the impact, families who have a baby might be thinking, well, we want to have another baby, we want to have another child, but we don't, want to put another child through this. And so having a diagnosis can open up opportunities for infertility treatments or prenatal diagnosis to help with planning for delivery management. But again, some of those might not apply to families. So I think it's important to answer why, what will it mean for your child? And then there's a whole other host of questions, which I'm sure we'll get to, about, which test is right and how do I know, when to stop and when to keep going. And I'll just finish with saying that, and we hear this all the time and we've heard this already, the idea that, a physician says, there's nothing we can do, this is not genetic. We have to think about, what medical school training was like 20, 30, 40 years ago, 10 years ago. I mean, just in my career, less than 20 years, so much has changed in genomic testing. So imagine a physician in medical school 40 years ago who is keeping up with so many different nuances of their specialty. Understanding genetics at a high level might be easy, but at a really detailed scientific level is challenging. And so we rely on medical geneticists and genetic counselors, but there's a huge shortage of those. And especially when thinking about wait lists to see a geneticist can be months in some clinic and some cities and some towns. And so there's so many different components. And so women like Brittany and Amber and other families like them have to advocate and fight for a diagnosis. And, if a physician says, I don't believe that this is genetic, say, well, I believe it is. And maybe it's not, but you have to continue to be that advocate because unfortunately, genomics is so complex that it's not something everybody can specialize in.
Well, Holly, that brings up a really, really great point. And there was a new guideline that came out and was released. And I think you are the perfect person to explain what it is, what it means, and how it can be a resource to the listeners we have on the call today.
Yeah, so this was a very exciting guideline. It was published 2 weeks ago tomorrow by the American College of Medical Genetics and Genomics. And it's the first guideline of this kind where it directly states that whole exome and or whole genome sequencing should be considered as a first or second tier test in patients in two categories. The first are babies that are born with a congenital anomaly, one or more. So even if it's an isolated birth defect, that still puts them in the right category up until 12 months of age. So even if it's a baby who's 10 months and was born with a heart defect, that still puts them kind of in this category. And then the second group, which I think touches a lot of families in the rare disease community, are intellectual disability and developmental delay up until age 18. And so what a guideline essentially is, and this is where terminology can be kind of tricky. You have recommendations and guidelines and points to consider from different medical societies. And a guideline is just that. It's a guidance for a physician, and it's based on systematic evidence. And so the ACMG did a very detailed systematic review of all of the literature, every study, case report, large randomized controlled trial that evaluated exome and genome sequencing in those populations. And based on that review, they feel like there is strong enough evidence to say that a physician should feel confident ordering first tier exome or genome sequencing. And it's great, it's a start. There's a lot more that needs to be done, partly because a guideline doesn't automatically equal insurance coverage, which we wish that it did, but it doesn't. However, this guideline is something that a family could use. They could go into their general pediatrician or neurologist or urologist and say, you may not be aware of this, but now we have this guideline. Could we use it to fight for coverage for genetic testing? Could it be used as part of a letter of medical necessity? So I think it's opening doors that maybe have been kind of more, cracked open or closed in the past, but it's definitely an important start for us.
Well, that's great. And I saw Gamal's comment in the chat that insurance is our worst enemy. And I think, thank you so much for touching on that this may not be exactly translate into coverage, but it is a first step.
Right.
I have to say, one of the things, and sorry, I just want to chime in. One of the things that I did the minute that Nash did have a diagnosis, which again, it took a little bit longer than we wanted it to, but I immediately contacted our insurance and I found a dedicated nurse to manage our case, because I knew that there were going to be so many different balls in the air and I was gonna have to have all these different approvals for a ventilator, for IV nutrition. I mean, you name it, we have it. Like, my house is literally a PICU. The only thing I cannot do in my house is put in a PIC line. So, I mean, everything else we can do there. But I have a relationship with a nurse, so I don't have to keep telling my story over and over and over and over and beating my head against a wall, because quite frankly, I don't have time for that. And that has changed the course for me. That has changed the course of my care for Nash. And we have had an insurance change since he's had his diagnosis. And that was like my ultimate fear, finding that one person who really connects with you, that listens to you and wants to be a quarterback for you, changes the relationship that you have with insurance tremendously, in my case. I would be happy to talk to Gamal, and you know, we had a bad case manager too. I see his comment. I'm not saying I can figure it out for you, but at least I can give you some of the tools that we used. I sent videos of my kid to our, I mean, I went crazy. You know, we were on ESPN, CNN, and I sent all the, you know, I sent videos and I said, you know, this is the only hope that we have, is there's this treatment coming, and we were able to make things happen. So I'd be happy to see if there's something maybe you haven't thought of.
That would be great, Brittany. I'm sure Gamal would appreciate that. And we are looking at the chat, and we will, Laura, I saw your question directed to Amber, and we will get to that at the end of this. And I did see a comment that the two of you are, Amber and Brittany, are superheroes, and I had to take a moment to agree with that.
Coming from a superhero herself, Effie.
We love you, Effie.
And so can we, Holly, before we move on, can we talk a little bit about the different types of genetic tests? Because they come in different flavors, and, you know, what are the differences and that patients need to understand?
Yeah, so it really has changed so much over a short period of time, and it's exciting, yet it can be overwhelming. And so you can have anywhere from a single gene test, and that might be a test for, let's say, SMA. Brittany talked about SMA earlier. It's pretty clear cut if there's a suspicion for a genetic condition, cystic fibrosis, achondroplasia, single gene test very well may make the most sense. And a geneticist or a skilled provider would be able to identify that. But then as you get into this grayer zone of clinical features, or phenotype as we call it, maybe it's epilepsy. So it could be multiple different genetic conditions. And so that might move to what's called panel testing. Panel testing has been around for a while, and it is a really efficient way to test for multiple genes at the same time. So of course it decreases costs and it makes it kind of an easier process. Panels, though, as great as they can be for certain indications, are not always made the same. So what's called an epilepsy panel at lab A and an epilepsy panel at lab B might be different. They might have different genes on them. And so a provider needs to really take into account, if they have a specific genetic condition in mind, that they order the right panel for that condition. Similarly, if a panel is done and it's negative, it doesn't necessarily mean that's a place to stop for some patients. And I think that sort of reminds us to always be aware of what testing has been ordered on my patient, on my child, and also getting your hands on those results, because you go to another doctor, and you want to be able to say, my child had this genetic test, not a genetic test, and it was negative. And as you get through into panel, there's also microarray, which some of the guidelines that are out there now for intellectual disability, up until now at least, have pointed to microarray. And that looks for lots of different changes in the genome at the same time, but it's still not, you know, completely comprehensive. And then we're now into a place where we call whole exome and whole genome sequencing are comprehensive tests. An exome sequences about 1% to 2% of our entire genome. And we used to think that everything else was junk and it didn't matter. And we know that that's not the case. So whole genome sequencing sequences the entire genome, coding, non-coding, everything that our genome is comprised of. And there are lots of different variant types. You could have a single base pair change, you could have a large insertion or deletion, triplet repeat disorders, which are common or seen in Fragile X syndrome, for example. So there's a lot of different types of changes that can occur. And so what's important for a patient to understand is not just what that genetic test is testing for, but what is it not testing for? Because if it ends up being negative, it's important to know, well, is it negative because I had a genome and I maxed out what I could learn? Or is it negative because it was an array and I need to go on to the next test? The other thing I'll also mention is that the reason it's important to know what you've had is, and this has kind of been a little bit more of a hotter topic, especially in the exome world for patients, is reanalysis. So as we learn more and more rare diseases and we start describing, oh, there's a new gene we've identified, there's a new mutation in that gene that we've identified, we're able to then look at tests that were maybe negative or uninformative from several years back and say, well, this patient had a variant we really weren't sure of. Now we're able to reclassify that variant as either benign or pathogenic or disease causing because of new information. So having a previous test reanalyzed is also an option, especially if a genome can't be done because of cost. It's cost prohibitory for a family. You can have an exome reanalyzed. And so these are conversations you need to have repeatedly with your physician, just to make sure that you aren't under the impression collectively that you've done everything that you can do. And I will assure you that in the next few years, there are going to be more tests. We're going to be sequencing RNA and looking at, protein function, proteomics, epigenomics, metabolomics. So there's all of these omics that are coming down the pike that are going to be really valuable, especially for neurological conditions and things like that.
Well, and I think you've raised a really good call to action for the parents listening, to keep track and to get the results in your hands as a first step. Thank you so much.
I wish I had known about it. I wish this would have saved me so much time and heartache, because you don't know what you don't know. We're not genetic counselors, we're parents, and we're terrified going to the doctor wanting to hear nothing is wrong, but knowing in our gut something is wrong. That's a terrible place to be. And a lot of times doctors will suggest some of these smaller tests, like we'll test for one gene. That's like one rock in the ocean. If I had gone in armed with the knowledge with this new literature that recommends whole genome sequencing, if I could turn back the hands of time, I would have walked into my pediatrician and said, I want whole genome sequencing, and this is why. I'm seeing an intellectual delay. I'm seeing something abnormal. How can you help me make this happen? And start lobbying for that the first day. You'll get answers so much sooner. And then you can start working on a treatment sooner. You can pair with a patient community. There's no harm in trying. Arm yourself with education.
I am so glad that you said that, Amber. Holly, did you want to add something?
No, I was going to say, beautifully said. And, we talked about this earlier when we had met before this meeting. And, yes, getting a diagnosis helps put you on a path. And that path may be treatment options, research. It may be choosing comfort care. It may be, future family planning for other family members, whatever that path is. And so having that information is important. But I still will kind of play the devil's advocate and say a diagnosis might not be for everybody. And whole genome sequencing might not be for everyone, because, you asked Sasha kind of what should patients know or what should families know about genetic testing. One of the things we know is that sometimes you can identify a secondary or incidental finding, and that can throw kind of a wrench into the entire kind of process of what's going on with your child. If you find out, oh, by the way, you're also a carrier for a mutation in a breast cancer genetic gene, BRCA1. And so now you have that added complexity on top of what you're dealing with in the moment. So yes, the information, and I will advocate for genetic testing all the time for all of the reasons Amber just talked about, but I'm trying to be, mindful as well that there are some families where it's just not time for them. It's not the appropriate option for them, and that's okay too.
I would also add that some of the issues with families who have very complex kids without diagnoses, that's something I come across very frequently. And one of the issues that families that I've talked to that we've come up with is that now their care is so complex, they don't have a diagnosis. Now they don't have insurance because they have to be on Medicaid because of how complex the care is. And Medicaid typically is not going to be advocating for this level of genetic testing. And so it creates another barrier for families to get answers. And I know, I'm lucky, we have wonderful private insurance and we're on Medicaid. And so we have great coverage, but from a genetic testing standpoint, when you don't have answers at that point, it creates a huge barrier. And I know for families, it can be devastating, exhausting, just trying to get somebody to agree to do it, and some families aren't in a position where they can pay. Most families aren't in a position where they can pay for genetic testing out of pocket, right? So this program is wonderful for that reason, so that there are ways to get around, I guess, hiccups that come along with these really ultra rare diseases,
Talking about the fact that both of you have hit on this, and Amber, you said you wish you had known that sooner, or you even got your results, that your parents, you're not geneticists. Can you talk about that, and basically what test did you get? How did you, get to the diagnosis? What were the costs involved? Did you get insurance coverage? And Brittany, please chime in and share your experience too.
Oh, it was annoying. I can tell you that much. We first went to the doctor after I was demanding genetic testing, and they said, sure, we'll go to the first level. Of course, I didn't know that I could request whole genome sequencing. And if I can leave everybody on this call with one phrase, whole genome sequencing, ask for whole genome sequencing. And so he said, sure, we'll do a test and we'll look for additions, deletions, or duplications. And we waited the 3 months. They came back and said, great news, nothing. And I said, oh, good. So nothing's genetically wrong? No. Now we get to go to the next layer. What's that? What do we do? Why do we waste our time? Why didn't you tell me I had an option months ago? Maybe I could have slept one night over the past 90 days. Wow. So then we went to a panel test. And what's annoying about that is, sure, they test a panel of genes. And it's some absurd number, 10 or 15,000 genes, but nothing like whole genome sequencing. And what a panel test means to one genetic company doesn't include the exact same set of genes that another genetic testing company may include. Again, if I had known and requested whole genome sequencing, that would have included everything. I wouldn't have had compared labs. Unfortunately, at the time, I had Blue Cross Blue Shield that basically insures you against the first 2 hours after a car accident. So I still have not received whole genome sequencing, but we have switched insurance carriers, and the cost has also significantly come down since 2017. So that is my next step as a family.
Wow. Yeah, Brittany, please. Sure.
So initially when Nash first started being, this Diagnostic Odyssey, we knew for sure from prenatal genetic testing that he didn't have SMA. Like I knew that with certainty. But there were still some characteristics that didn't make sense. So I was like, could this be wrong? We were tested twice. The first thing that they tested for was a disease called BOX2B. And it's a congenital hypoventilation syndrome. And that was the only thing that they tested for. And actually, even when we transferred institutions, so we were begging for genetic testing for an extended period of time, but genetic testing meaning whole exome or genome sequencing, since I knew that this was probably going to be something very unique. And we walked into our new institution, and the geneticist came in and he said, I have great news for you. Your son laying on that hospital bed right there is going to be running around in next summer with your older son. And I thought, oh my God, this is like, we're at one of the top institutions. This guy knows what he's talking about. Like, my kid is going to be fine. Right. And then ultimately, as we sort of went down the path of this, we ruled out FOX2B. We had done a microarray prior to our hospitalization through our pediatrician that came back normal. We knew from prenatal genetic screening that things were normal. And then ultimately we're diagnosed through whole exome sequencing, actually there's something called rapid sequencing. And basically Cincinnati did a wonderful job reporting the characteristics that Nash is exhibiting. And they were able to really, within 5 days, figure out the diagnosis. However, I will say, after Nash had his diagnosis, because he was doing better than most people with his disease, there were questions as to whether or not he had the right diagnosis. And so we started down this whole reanalysis journey, which who knew that genetic testing can be, quote, wrong, or, have other things that are added to it. And ultimately going through IVF and PGD, we figured out that that was absolutely the right diagnosis, because our embryos were affected with my husband's mutation or my mutation. And, and here we are, we have a healthy little guy today. So.
And so just to kind of piggyback on that a little bit, Brittany, the whole reanalysis thing, that's something people really don't know. They think that they've had a negative result and therefore that's it. But because technology is evolving so much, and, if you think about it, but even individually, the cost of a whole genome sequencing right now ranges anywhere, I would say, from maybe $5,000 to $12,000, although it can be much more. And if you think about the cost of a single gene test or a panel, that's a couple of $100, and then another panel, and then a microarray, that's a few thousand. This starts to add up. So these sort of incremental individual genetic tests add up to as much, if not more, than what a whole exome or a whole genome are. So from the insurance company's perspective, it makes sense for them to want to pay for one test that's more comprehensive. But exome is great. A lot of insurance companies are covering it. In fact, there was some research that was done that looked at the number of insurance companies that are covering it or have a policy to cover it, of course, minus your copay and coinsurance, but that the utilization was not up to where you would expect it to be based on the number of rare disease kids that 2 to 6% of the population. So even though it's covered, it's not being utilized. And so why does that gap exist? And it exists because of the providers just not knowing that whole exome sequencing is available.
And to piggyback one more time onto what you were saying, we actually, because our gene is a newer found gene, we have a family who just recently contacted us, a 26-year-old who was misdiagnosed with a muscular dystrophy his entire life. They did a reanalysis. They were doing a reanalysis for him every, certain period of time, from my understanding. And finally, after his 26th birthday, he finally for sure has the right diagnosis. So reanalysis is very, very beneficial for sure for a lot of people.
Sasha, I see that there's a question about getting whole genome sequencing testing and what support is out there. Now with the new guideline, that might be helpful in any fight that you're currently involved with in your insurance company. So that's sort of a new piece of information that you could use to go back to your insurance company and say, okay, now it's a guideline. Alternatively, there are philanthropic options. And it's always really important to pay attention. If you have an opportunity to have genome sequencing done or exome sequencing done at no cost through a research, you need to know, is it research or clinical testing? Because if it's research, you may not ever get a result, or they may say, well, your result will be available in 12 months. Whereas if you do it under a philanthropic, for example, the Undiagnosed Disease Network is a government-funded program for any kid who has not been diagnosed and meets criteria. They can enter into the UDN and see if they're accepted, and then perhaps have whole exome or whole genome sequencing. Illumina has a philanthropic offering as well through a program called I Hope. that you can Google online and see if that's something your provider is able to work through. And then as far as reanalysis goes, because this was all kind of from the same person, reanalysis, yes, in theory, it costs the lab money to reanalyze because it costs people time to sit down and reanalyze the variants, because it's very much a hands-on process, but there's no reimbursement for reanalysis. And so that's where a struggle is for a lab to say, sure, we'll reanalyze you every 6 months, because there's no reimbursement as of yet for it. But it can be done at a fairly nominal fee.
Well, and also one of the things I see that there are a lot of foundations that are on this, from the attendees, or however you say that word, attendees. One of the things as a nonprofit that I did immediately, even before searching for a researcher or to find somebody who could help us, I went to a lot of genetic companies and asked, like, is there a reason that on the differential diagnosis for SMA that SMARD doesn't exist? Or is there a reason that on Charcot-Marie-Tooth, which is a peripheral neuropathy, which is what SMARD is there a reason that that's not on the differential diagnosis list? So that when you have these panel tests that you go and pursue, that the doctors who are not going to the whole genome sequence right away, that at least this could be it could be an option to discover that this could potentially be. So one of the suggestions I have for foundations or organizations is, if you haven't done that yet, contact the right people and I can help you contact the right people at these genetics companies to get your, if you have some sort of seizure disorder and you have the diagnosis, but your families are having a hard time getting a diagnosis, maybe it needs to be on an epilepsy panel, or and there are things that you can do to work through that I'd be happy to help with as well.
Well, let's, I think, because we're getting so many questions, we can close. And one last question. What is, and then I'll give closing remarks, but what, if you had to say a lesson learned or something you wish you had known before, and what, for either one of you, Brittany and Amber, what would you say? And also Holly, if you've seen parents that there's something that you've seen on a pattern that you could offer and share with others as well, lesson learned that you've seen has benefited them, that would be great.
I would say for me, the number one, if you have a gut instinct that there's something wrong, don't ever, ever, ever let anybody dull that instinct. And know that you can ask questions, and you don't have to accept what you're hearing. You are entitled to ask questions about your child or about yourself if you're representing yourself, and even with your partner or your spouse. I mean, same thing. My husband and I adore him. He's the greatest guy in the world, but he started questioning me too. And I'm like, you're either going to be in my way or you're going to be on my side, and you better choose wisely, because I am not kidding. It will be done. This is my kid. And so I would say, your instinct is number one. And number two, do not stop pushing. Do whatever it takes. I know a lot of people lose energy, but ultimately the amount of energy that you put into this, you will get back out. So
I echo everything Brittany said. My biggest advice is to follow your gut. And it's super uncomfortable to sit there and question a doctor who has been in the profession for 30 or 40 years.
Who's telling you you're
not
crazy?
God.
Who's telling you that you're crazy?
Yes. Yeah. Who is actually questioning yourself and making you feel really bad about yourself. And what I can say in that instance, and what has driven me since, is that I have nothing to lose. I'm not even fighting for my own life. I'm fighting for my child. And I will walk to the end of the earth and do anything to help them. So if you can't help me, introduce me to somebody that can. And I need an appointment now. Keep pushing and arm yourself with education. Like I said from the beginning, we talked about so many small terms like panel testing, microarrays. That's a lot of time on Google when you can just start with whole genome sequencing. That's what I want. And the doctor will say why. And you can say this article right here, 2 weeks ago. You may have missed it. Let's talk about it.
And Holly,
I think the lesson that I've learned from hearing other parents is, just unfortunately, we do live in a world where you have to be the expert. Of course, you're the expert in your child's condition and what your child is experiencing on a day-to-day basis, but you have to become kind of a mini expert. And there's some resources out there. I know Global Genes has a Genetics 101 that really takes a deep dive into different mutation types and different genetic testing types. There are other resources out there. We at Illumina are always trying to do kind of meaningful education for physicians, healthcare providers. But you really, I think I hear time and time again that I wish my pediatrician knew more. I wish my pediatrician knew more. And so that's a lesson that I take when I think about what we can do as a company to sort of impact implementation.
I have one last thing, piggybacking from the pediatrician. Find yourself a pediatrician that listens to every single thing that you say and can tell you that they don't know, and that they will find somebody, or they will support you in finding somebody that will. That I had a different pediatrician who was wonderful for my normal child. Loved her, but if I did not have our current pediatrician, Nash's outcome would have been entirely. And it's because he listened and he wanted to help. So that's another huge thing for us.
Thank you, Brittany. And as everyone on this call can see, that a diagnosis doesn't mean a clear path forward. There isn't a protocol at most hospitals that describes next steps for parents to take when they are looking at what they have to do to develop a cure. We'll explore all of that in this series that we're going through, and we hope that you'll join us for the next one. We just want to thank you for joining us. We're going to go into questions. But it's been a privilege to benefit from your journeys, Amber and Brittany, and your knowledge, Holly. Thank you. And I'm sure listeners have gained a lot of information. For more information, we are going to put in the chat. For each session that we have, we're going to have an associated blog with the information in a written form, so you can read about it in more detail, and we'll have resources on that. And we have a list of testing providers on the blog that we're going to be inserting at the bottom of it. We also have a link to the press release of the guidelines that you can print out or save on your phone and bring with you to your provider, so that you have that resource. And also, if you want to subscribe to get updates on the next series, the subscribe option is to the right on the blog page, and we will alert you. We will not bombard you with a lot of emails. We'll just share with you when the next session is, and you'll get a copy of the next article that we write. This session was sponsored by American Gene Technologies, who cares about everyone on this call and about the families that are undergoing these stresses. We are working hard to create cures for rare diseases. And I think one of the biggest things is we really encourage other biotech companies like AGT to join us as well. And we really encourage those in leadership positions to fight for these families, to make life easier, to develop cures, and to make it easier to organize clinical trials. So we encourage the community. It is a joint force, and as you've learned from these mothers, no is not an option. I think we all need to come together and push for making, everyone's life a lot easier. And Amber, I've heard you say this a lot, but rare isn't, so rare. If you combine the number of families that are affected by rare diseases, it's quite a large population. So we really need to stand together. So
Amber and I like ruffling feathers. So you can contact us and we'll ruffle feathers with you.
We'll help.
Amber and I call each other like twice a day, and we're like, okay, who pissed us off today? How can we fix the problem? Excuse my language, but like, how are we going to fix the problem for this problem?
You raised such a good point, and I thank you so much for saying that, Brittany, because we do want everyone that's on this call to be in touch on the long term, because we are trying to band together. And we've listed both, and I'll make sure when I stop talking that both of your websites are there. If anyone wants to donate, they can. Definitely, we have the subscribe option that will hopefully turn into a united force, like you said. And I'm sure you've made it clear that it's okay if others contact you, and we work together to get things done. So jumping into questions, I first wanted to ask the panelists, did you see any questions that you wanted to respond to right away that we could start with? Otherwise, I'll go down the list.
Lakia, who I adore. Hi, Lakia. She said, how do you press the issue when there are 2 people in the world with the mutation, or at least get them to name it? And then she said that there are 4 now. I've talked to Lakia a number of times. We've pushed actually at Boston Children's for some help for her son. Hopefully we're going to make some progress there. She's been getting door closed in her face time and time and time again. And so to answer your question about getting the name getting a name for your disease, it's interesting because SMARD is so confused with SMA because of the name. So this is a question I actually just started pursuing recently, started pursuing the answer to, because it's been a huge fundraising obstacle for us. And, you know, the answer in the very short term, from my understanding, and Amber, you might have more to say about this. One of Amber's disease also doesn't have a name. It has a gene associated with it. But for us, I want to continue to have a discussion about changing. And they say that what we've been told is that going to Congress and trying to start there, going to Congress and trying to get the name, either get the disease named or get the disease name changed. And then also as an organization, if you start the organization, especially because you only have such a small patient population, you sort of can change the name of that disease and create awareness for it associated to the mutation. And Holly, you might also have a better answer than that, but that's sort of where I started with the name change. So.
Yeah, I don't know much more about than what you know. I've heard people talk about it before. Yeah, it is, you know, again, back when I was training 20 years ago in graduate school, most of the conditions were names, you know, Noonan syndrome and cystic fibrosis and achondroplasia, you know, it's a name, Williams syndrome, but now it's these genes. And part of it is because we are discovering so many more genetic conditions so much more rapidly than we were before, that it just becomes now a little bit easier to defer to it, but putting a name makes it real, you know, instead of just calling it by a mutation or a gene, it makes it real, and helps give it a voice. So I definitely agree with the efforts that you know, advocacy groups make to do that.
In our case, since nobody claimed it, and now we actually have a much higher prevalence. So we thought Maxwell was 1 of 34 when he was diagnosed. That's not true. He's 1 in 35,000. And for everybody listening, what that means, excuse my cat, is that this disease actually isn't all that rare. We're on the prevalent side of rare. We're the 10th cause of autism, 6th cause of epilepsy, and play a role in many psychiatric conditions. So because nobody claims our disease, I had the idea that whoever cures it can name it. Name it after your cat, name it after a TV show. I don't care. Just cure the damn thing. And then you have this legacy of a feel-good legacy of naming a disease because you cured it.
Well, we're going to go down the list of questions. I did want to, Laura wrote a question directed to SLC 6A1. Wanted to see if maybe you wanted to follow up separately with her on that, or if you have something you think other parents would want to hear on the call.
I replied to a lot of these questions at one point during the session, just in case we didn't have time to get to it. And I also put my personal email in the chat if people want to connect with me offline. But Laura asked if one of her children has SLC 6A1, should she have the others tested? And this is I'm not a doctor, not a scientist. Last science experiment around 4th grade, the sea monkeys died. Don't take my medical advice. But my parent advice is, if you have this, it's very possible that one of the parents could be a mosaic carrier. It's possible you could pass it down. If your children are symptomatic, even if it wasn't with, even if you weren't suspecting SLC6A1, there's really no harm in seeking a diagnosis or having genetic testing.
Yeah. And some people may worry about the harm with insurance discrimination with having a genetic diagnosis. And I don't know if that's something that in the rare disease community is talked about a lot. I know in the, let's say the cancer community, it's definitely a concern. Do I have a genetic predisposition for cancer? There is a law in place that you cannot have genetic information discriminate against for insurance purposes. And so there's, the law is there. Does it mean that there aren't opportunities down the road for there to be some type of discrimination? Certainly. But again, that applies to health insurance and not necessarily life insurance. And so one concern that a lot of families have is, well, if I, incidentally find out that there's a gene in my family and does it impact my child? If my child finds out that they're a carrier, not so much if they're a carrier, it really is if they have a gene. And so, the diagnosis and the clinical sequelae that a patient would exhibit would supersede any genetic diagnosis. So it's the clinical information. So if your child is already suffering from a condition, doing the additional genetic testing is not going to compound any perceived insurance discrimination. So my point there is, don't let that put fear in you for pursuing genetic testing.
That's great. Thank you, Holly. Amber, I just wanted to mention, I think the panelists got the responses to some of those questions. So let's follow up later and make sure Amber put her email in the chat, so you can reach out to her separately, but we'll follow up after this to make sure everybody gets an answer to their questions. Let's see. I know I saw a question in the chat. Can we have the link to this literature? What is the name of it if I Googled it? Is this, Charlene, I think you're talking about the press release. We put it in the chat. So if you're not, though, please respond and write another Q&A. Sorry to ask you that. And then Lakia, Amber, you replied to Lakia's question. How do we press the issue when it's 2 people in the world with the mutation? Yep. Or at least, okay.
There is another one from Charlene that I don't know, it's in the answered area, but I answered it and I said, let's talk about it live. So it actually wasn't answered.
Oh, great. Perfect.
Are there getting started or programs out there that will assist in paying for whole genome sequence testing? My daughter has epilepsy, 22q duplication, CAC, NA1A, learning difficulties, adrenal issues, thyroid issues, and more. Her epileptologist, wants her to do whole genome because he feels like we could be missing something that we can't get her seizures under control. I have only one suggestion for that, but again, Holly, this might be something that you can.
Yeah, I think when I mentioned earlier, the Undiagnosed Disease Network may be a great resource. I know that their funding actually is running out in sometime this year to continue, but they're hoping to plan to continue having available genomic sequencing moving forward. There's other research opportunities out there, but then I mentioned the iHope program. So you can Google iHope. It's an Illumina philanthropic offering, and not everybody is a candidate, but it could be a resource that's available for a patient to look into with their provider.
I know there's another, and I don't know a ton about it, so forgive me if I'm being ignorant by saying this, but the Baby Bear Project.
So that's different. So Project Baby Bear is newborn NICU, so acutely ill, critically ill infants with rapid whole genome sequencing. And Project Baby Bear is actually published, so it's no longer an ongoing project. However, it did lead to efforts in the state of California. So if you're in California, Blue Cross Blue Shield has a policy to cover whole genome sequencing in the NICU. Other states have policies too. And then, in the off chance somebody on this call is from the Boston area, Harvard Pilgrim Healthcare has agreed to a risk sharing where they are going to allow patients who would have met the exome sequencing criteria to actually get whole genome sequencing, and it's a covered benefit. And so they're doing this as a way, actually with Illumina, to show that it doesn't cost them more money to offer whole genome sequencing. So it's one small insurance company, but it's these little efforts that our company and other companies are making that are trying to help tell the story that there is economic and clinical utility behind genome sequencing. So, sometimes just Googling insurance, whole genome sequencing, press release might pop up. But Project Baby Bear, anything that says Project Baby is for a NICU PICU setting.
That's
There's several.
But Charlene, I would say let's talk, because I think that there are, let's talk, because I think that there are definitely ways that we can work the system. I've learned to become really good at it, unfortunately. So let's talk.
Thank you so much, Brittany, for being so generous with your time to help everyone. Do you guys see, I see Lakia had one other question. What is the best way to find a list of researchers, especially, to help with the treatment or cure for her child? I know we're going to hit on that in our other series, but I don't know if anyone wants to touch on that. I would say definitely stay tuned, Lakia, and subscribe to get notifications on the next few series, because even if we dive into it lightly now, we'll get into it more thoroughly later.
So like I said, I've talked to Lakia a number of times, and we can talk more about this, Lakia, when we have our next follow-up call. Unfortunately, there's not like a great path forward to finding the perfect researcher. I know I've reached out, you've reached out to a number of different organizations and institutions, but I think that taking those papers that do exist about King Nazir's mutation, that's Lakia's son, and really, I mean, contact even the people that aren't important on that paper, because they might have something important to say. And then the other thing for me that I did, I found the person who discovered the gene, and I found out some really interesting information from that person. But I mean, anybody who's ever put that gene in a paper, contact those people. Anybody who has, if you're trying to pursue gene therapy, contact anybody who's had experience in pursuing gene therapy and delivering it to a human. Contact other families like Amber and myself. There's, like Amber said, there's a lot of us out there, and we can help you sort of compile a list, but start with every single paper that has that gene in it. Contact every single person on those papers. That's what I did. So, and I know that's what Amber did as well. Sorry, I'm speaking for you, Amber.
No, I think as individuals pursue these individual efforts, I still encourage you to join or subscribe on Amber's site, so that not only can you accomplish those individual efforts, but then we can, as a united force, make change for all of us. Did you guys see Laura's question? Amber, I think this would be directed toward you. If
she asked me, but now it's directed towards Holly, and I can give Holly an overview, and I answered, I typed out an answer in the chat as well. Holly, I'll give you an overview. This woman has a child with SLC 6A1 and another condition named SLC 13A5. They both present similarly. I would categorize us as sister conditions. I would categorize her luck as some of the worst I've seen. Only one child has been genetically tested, and this child has siblings. What do you think about testing the rest of the children in her family?
Well, I don't know enough about the 13, the second condition, to know if they're, because again, some conditions have reduced penetrance or variable expressivity. So where they might not have any symptoms in one individual, but have severe symptoms in someone else. So that would be a reason. But I think if the conditions, both gene conditions, are known to be associated with some type of clinical phenotype that would be evident right now in their affected children, then I would say there's probably no need to do it. It would be important carrier information, because when they want to go on to have children in the future, they might want to know, am I a carrier? And therefore, would I want to have my partner screened as well? But that would be the only reason that I would think of genetic testing being important, is for carrier testing. But SLC6A is that's dominant, right? Is it a dominant condition?
SLC6A1 is SLC13A5, I believe, is recessive. So
It's
both
recessive,
parents
okay.
need to pass it down.
Amber, isn't Maxwell, wasn't his de novo? It was not inherited.
Yeah, that's
Maxwell
usually a
is
rare
de novo.
disease. When they're dominant, they're usually de novo. And
No.
so that's why I wasn't sure. But again, like, there's so many genetic conditions that I just don't know the inheritance and the clinical picture of all of them. But if the 13 is recessive, then that's where it would maybe be important to do testing down the road for those children. But when they're adults and they're ready to do it and ready to, for family planning. But I think if the physician feels like the children are not at risk of being affected because the genes themselves would have expressed some type of clinical features at this point, then I don't think that there's any reasoning. Because when I read this question, I thought the question was, after a diagnosis from a panel test, should that patient, that affected baby or child, then have sequencing? And the answer to that would be no, if they're not concerned about a second diagnosis, which it sounds like there's already been one that's been identified.
We did test our older son for as a carrier. And to your point, I mean, he's only 7, but like having conversations about making really, really good decisions in high school, like hopefully college, maybe later down the line. We also, knowing that there's a treatment coming up that we've developed, is we wanted to be 100% certain. We've seen the same phenotype present in different ways in our disease. So we wanted to be sure that there wasn't we were missing something along the way, just to be 100% sure. So, there are reasons to pursue it, but it doesn't always get covered.
Right. That's the thing. If there's no indication for it other than just information purposes, then it may not be covered. And again, whether or not somebody's a carrier is not going to cause genetic information discrimination, because carrier doesn't impact that person's physical health. That's not always the case. So there's certain excellent conditions where that could be the case, but in general, for recessive conditions, it's not.
Yeah, Laura, and my son's disease is recessive. He inherited it from both my husband and myself. Again, I'm happy to talk to you about the question as well. And if you want to pursue it, I will help you push for it. There was sort of no reason that they wanted to test my son, and we were able to get it approved. So
I did see a question from Gamal about how can we lobby the NIH to invest in rare diseases. My objective for the NIH is to establish an institute and not an information center. I have thoughts about that. Did you guys want to share yours too?
Good luck.
So there is, the NIH has the NHGRI, right? Which NHGRI does a lot for genomics education, genomics information. There are grants that you can apply for different research endeavors in genetics. And in fact, I believe the approved budget for those is higher than it's been in previous years. And so that's good for people doing research. So I think in that respect, the NIH is doing a lot to invest in rare disease. But again, Sasha, I don't know what your thoughts are.
Oh, well, I was going to mention the one positive thing was the FDA orphan drug designation, which we got for PKU. Just the fact of making it more attractive to invest, for biotech companies to invest in cures. I think there's a lot more we need to do. And I think Amber probably has a lot of comments, but I think that was one of the, core reasons why we wanted to start this boot camp, is to motivate more progress and support. So I think in us coming together and exploring those ideas you have, Gamal, and working together and pushing the needle is something we'd like to do. So, but Amber, did you want to mention something?
Yeah, I have a different thought about this. I think, and I weirdly got the idea by watching Bohemian Rhapsody. the movie about Freddie Mercury's life. And I was watching Bohemian Rhapsody, and I had forgotten that there was a really terrible stigma attached with HIV and AIDS in the 80s and 90s when Freddie had it. And of course, who doesn't love Freddie Mercury? Like, anytime a song comes on. And it just broke my heart to think that he died kind of shamefully. And I was thinking about how that has changed over time. And the conclusion I kind of came to is that everybody thinks rare diseases can't happen to them. And rare diseases are considered too rare to care by people, by biotechs, by government. Oh, that's a rare disease. No, it's actually not. There are 7,000 rare diseases. 1 in 10 people are affected by one in the US. 50% of rare diseases affect children, and only 30% will live to see their 5th birthday. That's terrible. And the AIDS community didn't really make an impact on the rest of the US and the world until they marched on Washington, until brothers and sisters were getting diagnosed, and it no longer became characterized as a gay plague to something that could happen to any one of us through no fault of our own. And over time, that changed the stigma and the way we think about things. Part of the reason my family has made our story so ultra public, it's not fun. I never updated Facebook in my entire life. I never wanted to be able to Google myself. That was actually a worst fear. And here I am, Googleable. Anybody can find me, contact me at any second of the day.
Your number 1 search when you Google rare disease moms.
Oh my gosh. Well, hopefully SLC 681 will start showing up higher in the search engine. But I really want people to see the story of Nash and Maxwell and understand what we're going through, and that science is a solution when there are none. We need science to advance cures, and what we're doing has transcended our little families. We have the opportunity to help so many people. We can start curing some of these single gene disorders. Of course, we'll be able to impact Alzheimer's, Parkinson's, ALS. And so I really hope to destigmatize rare disease.
I love that. And as a company that is working on an HIV cure and works with survivors, I completely agree. The banding together and marching on Washington was really effective, and I think we can do that together in this case as well. So I think sharing your story, I think that's one thing that sounds like it has led to the success. As a marketer, brand awareness and building brand awareness through your own social media platforms is a wonderful way to build that awareness. And I think both of you have done a tremendous job at doing that. And on this call, I think I don't think anyone really understands the gravity of what you go through on a day-to-day basis unless they see your social platform. Because definitely on this call, we're trying to offer help and resources, but we're not getting into the details. But I think you both sharing what life really looks like and bringing awareness of, Amber, in your case, a recent experience you had with your clinical trial, putting that in the limelight definitely gets eyeballs and brings awareness. And that's what ultimately we're trying to do is build more awareness for rare diseases. And that often moves the needle. And I think numbers, banding together, that definitely helped in the HIV community. And we need to do that as well as a united force. So
Amber and
At
I
least
said,
that's my thought.
Amber and I said we're gonna go streaking down Capitol Hill. They're gonna be like, get your clothes back on.
That'll get their attention. They won't be able to
naked
ignore you
pictures
then.
until like, oh, I like to say I'll post naked pictures until a good Samaritan just funds the gene therapy
Exactly.
so that I can help the world by taking them down.
Oh my goodness.
But there
Yeah.
are a lot of obstacles with the NIH, and like for my son's disease, I do know that time would not even allow. Like I was like, he is on borrowed time at the time. Again, he was, just over a year old, and now by the grace of God, knock on wood, he's 4.5, but he's very, very sick. And we did not have time to sit and wait to progress research for the NIH. And that has to change. I mean, and we have to figure out a way as a group to be able to change that so that families don't have to go through that. So I don't have the answer to that question, but I have the same concern.
Yeah. And I definitely, this is going to be something we continue. And I think if we keep sharing ideas together, and build that as a marketer, I'm happy. I'll put my contact in, dedicate free time to anyone who wants any ideas for building brand awareness. But I definitely think it can help move the needle, but I think we can do that together too. Well, does anybody see any other questions they'd like to cover? No. All right. Well, thank you so much. Thank you, Holly, Amber, Brittany. Thank you so much for today. We hope to do many more together. And, thank you for all the great questions that came through. And I did see one in closing. I did see one great question. And I think it was, I can't remember if it was Laura, but it was that, isn't it ironic that the people that are called crazy are the people that get things done. And I think that, that trusting your intuition and, fighting for what you believe in and what is true is such an important thing we can take away from this. So thank you so much. I wish everybody a great day.
There's another question. I'm sorry. I just want to.
Yeah.
Miles said, I contacted Jackson Laboratory and asked about mouse models of rare disease. What's your opinion on this research strategy? Like if you can fund it or they have the funding or whatever it might be. I know Amber went to China for a mouse model. For my son's disease, we didn't need a mouse model after him to know if the treatment was going to work. But all of our mouse models were through Jackson Laboratory, and we've had wonderful success. So I would say if it's something that
I like Jack's too.
Yeah, if it's and I've directed a lot of rare disease families to them. So if it's something that you can pursue financially, or if it's something that they're willing to do pro bono or whatever it might be, I would say definitely do that. And yeah, I would just, Sasha, the one thing you had said is speaking for yourself and whatever. And I always come back to this Martin Luther King quote. That says, I came to a conclusion that there's an existential moment in your life when you must decide to speak for yourself because nobody else is going to speak for you. And that is something in at least my case. And I know in Amber's case, I know nobody still to this day, nobody is going to anybody to try and figure out how to help us. It's been on our shoulders, and I pray for the day that it's off of them. But, so just keep speaking up and getting loud.
That's a beautiful message to end on. Thank you, everyone.
Thank you.
Thank you. See you in our next session. All right. Bye.
Have a great day.
You too.
Bye.
Bye.